Hello and welcome to Medical Oasis, and to the second lesson of Hematology chapter. I am Dr. Eve, and I will be speaking today about the microcytic anemia. So let's get started. Microcytic anemia, as I mentioned in the previous lesson, is defined as a low mean corpuscular volume, usually below 80, and a low reticulocyte count. The most common causes are, number 1, iron deficiency, which is caused by blood loss such as menstruation. As we know that the body only needs a very tiny amount of iron, in the range of 1 to 2 milligrams per day. This range will eventually increase in menstruating women to 2 to 3 milligrams a day, and in pregnant women to 5 to 6 milligrams a day. Please keep in mind that as little as 1 teaspoon a day of blood loss will lead to iron deficiency over time. Number 2, chronic disease, which includes any form of cancer or chronic infection. In this case, the iron is locked in storage, or trapped in macrophages, or in ferritin. The hemoglobin synthesis will not occur because the iron just does not move forward. Number 3, sideroblastic anemia, that results from the inability of iron to be incorporated with heme. Number 4, thalassemia. It is an extremely common cause of microcytosis. Most patients with thalassemia trait alone are asymptomatic. How to diagnose microcytic anemia? Well, we could start with the peripheral smear, but it won't be that much of help as it will have same result for all of the causes of microcytic anemia. So the best tests to do next to get the differential diagnosis of microcytic anemia are the iron studies, which includes ferritin, serum iron and transferrin, followed by red cell distribution of width, and total iron binding capacity. The test's result will be as it's showing in the following picture. As we notice here, the serum ferritin is only decreased in iron deficiency anemia and increased in thalassemia. The red blood cell distribution width is increased in both of iron deficiency and sideroblastic anemias. Also, the serum iron and transferrin levels are decreased in iron deficiency and normal in everything else. There are also other laboratory tests that I would love to mention briefly, which suggest specific diagnosis, such as Prussian blue staining for ringed sideroblasts, which is the most accurate test for sideroblastic anemia, and hemoglobin electrophoresis, that is the most accurate test for thalassemia. Now, and after we have got to know how to diagnose this microcytic anemia, it's the time to treat it. Well, treatment varies, and depends on the underlying cause. So let's talk about them one by one. In case of iron deficiency anemia, the management, it's easy to remember. You lost iron, so just replace it with oral ferrous sulfate. In anemia of chronic disease, treat it by correcting the underlying disease plus erythropoietin replacement if only the anemia associated with end-stage renal failure. In case of sideroblastic anemia, the correction of the underlying cause with vitamin B6 or pyridoxine replacement can manage the anemia well enough. In thalassemia, the management depends on the type. So as for thalassemia trait or thalassemia minor, there will be no treatment needed. But in case of beta thalassemia major, management will be with lifelong chronic transfusion, which can lead later on to iron overload and is managed with deferrasirox or deferriprine, oral iron chelators. Finally, we have reached to the end of this lesson, and as previous lesson, I would like to end it with a question. I will give you few seconds to think about it before I give the correct answer. So, ladies and gentlemen, the question is, why will the red cell distribution of width be increased in iron deficiency anemia? This is because the newer cells are more iron deficient and smaller. As the body runs out of iron, the newer cells have less hemoglobin and get progressively smaller. Now we are done. Thank you for your listening, and see you in the next lesson.